Happy Wednesday, everyone, and welcome to today's webinar, Social Determinants of Atrial Fibrillation, Learning from the Past to Transform the Future. My name is Gino Malika, and I'm the Quality Programs Manager for Get With the Guidelines Atrial Fibrillation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be sent out within 24 hours. There are no continuing educations associated with this webinar, but you may access your certificate of completion in your follow-up email at the conclusion of today's event. You will have the opportunity to submit questions by typing them into your questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. If you are experiencing any technical issues, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. At this time, I'd like to welcome my colleague, Jeannie Luciano, Senior Program Manager for Get With the Guidelines AFib.
Hello, everyone, and thank you so much for joining us today. We are honored and delighted to have a fantastic speaker, Dr. Utebe Essien. Dr. Essien is a board-certified internal medicine physician and assistant professor of medicine and health equity researcher at the University of Pittsburgh. Dr. Essien received his MD from Albert Einstein College of Medicine and is trained in internal medicine at Massachusetts General Hospital and Harvard Medical School. After residency, he remained at MGH to complete a research fellowship and receive a Master's of Public Health degree from the Harvard School of Public Health. Dr. Essien's research focuses on racial disparities in the use of novel medications and technologies in the management of cardiovascular diseases. Dr. Essien has coined the term pharmacoequity, providing a new framework of achieving equitable access to care. He applied his health equity frameworks to the COVID-19 pandemic, becoming an expert in examining the disparities that disproportionately affect minority communities with COVID-19. His work has been featured in leading medical journals, including JAMA, the Annals of Internal Medicine, and the New England Journal of Medicine. And he has been featured on several national news outlets, including the New York Times, Washington Post, and NPR. Dr. Essien has received nearly $2 million in research funding from the National Institute for Health, the Department of Veterans Affairs, the American Heart Association, and the Robert Wood Johnson Foundation. Dr. Essien is a fierce advocate for diversity and equity in medicine and is highly sought after as a speaker on racism and health, leading national seminars and keynote speeches while co-directing an anti-racism in medicine podcast. Dr. Essien's leadership in advancing health equity led him to receive several national awards, including the 2019 National Minority Quality Forum 40 Under 40 Leaders in Minority Health Award, one of 30 Leaders Under 40 Transforming Healthcare by the Business Insider, and one of 20 top Black physician social media influencers in 2020. And the Association of American Medical Colleges Herbert W. Nickens Faculty Fellowship Award in 2021. This is, you can sit back and really enjoy a real treat with our featured speaker today. So Dr. Essien, I hand it over to you.
Awesome. Well, thank you so much for that introduction. I'm really thrilled and honored to be able to share with you all today. On the title of my talk is The Social Determinants of Atrial Fibrillation, Learning from the Past to Transform the Future. And I have no conflicts to disclose, sharing some of my grant funding here. The one thing I'll disclose is that as much as I tried, I could not include a Earth, Wind, and Fire reference to their September 21st song, but darn it, I did try hard there. So here's what we'll be discussing during our brief time together today. 3 objectives. We'll discuss and identify atrial fibrillation as a really important model disease for studying the social determinants. We'll examine a few key social determinants of atrial fibrillation, and we'll close out hopefully by describing some opportunities for future research in the social determinants of AF. And so let's jump into the first objective, identifying AF as a model disease for studying social determinants. And before diving into the AFib conversation, I did want to share a little bit about my journey to this work. I always think it's really helpful to kind of hear the trajectory, the story, the narrative, which I think is critically important when thinking and talking about the social determinants. So here's a little bit about how I got to this work. And the buildings on your screen here are a little bit of my journey towards medicine. So the top left picture there is a picture of Bellevue Hospital, which is one of the largest public hospitals in the world in New York City. And that's where I volunteered as a freshman undergrad at NYU in the emergency department, really getting my first foray into medicine, seeing patient and community members who were really using the emergency department as the primary source of primary care. A few years later, I finally got through the MCATs and pre-med requirements to attend medical school, and I attended school at the Albert Einstein College of Medicine, which is pictured on the bottom left here. And one of our teaching hospitals up here was Montefiore Medical Center. And that was another kind of teaching hospital, lots of patients filling the ERs and the inpatient wards every day. And after graduating medical school, I made my trip up north, so to speak, to Boston, where other than hating Tom Brady, sorry to all the Massachusetts fans on the webinar, I had the opportunity to serve as a primary care resident here at the Massachusetts General Hospital and out in Chelsea, which was where I had my primary care clinic. And I would spend every Tuesday morning driving out to my office there on the second floor to take care of patients who really transformed the way I think about medicine. And what was one of the key lessons that I learned there after going through my undergrad volunteering, my medical school training at the various hospitals, was that despite most of our training taking place in buildings like these on your screen, that's really not where our patients' health was being impacted. And that it was these factors that extend way beyond the hemoglobin A1C diabetes test that I order or the echocardiogram that I refer patients to. But it was really that was impacting their health. It was really what was going on outside of these four walls that the patients on communities often come to visit us in. Those factors, those terms, those phrases, as many of us know well, have been referred to as the social determinants of health, or how these factors such as social and community context, neighborhood and environment, education, the places where our patients live and work and play really impact their health far beyond some of the things that we do on a day-to-day basis in our clinical care. And these were factors that I became pretty obsessed with during my residency and my research fellowship training, really spending time understanding how food insecurity, for example, influences patients with diabetes, or how housing insecurity or homelessness affects patients with diabetes as well. And of course, thinking about how these social determinants impact the topic we're discussing today of atrial fibrillation. These are a handful of papers that we worked on during my residency and my fellowship. And around the same time, the American Heart Association was also becoming consumed by the social determinants of health. And this was a scientific statement placed in 2015, which had the quote that is on your screen here that says, "At present, the most significant opportunities for reducing death and disability from cardiovascular disease lie with addressing the social determinants of cardiovascular outcomes." And again, it wasn't just the AHA, but several healthcare organizations, institutions, and societies were really increasingly paying attention to the social determinants as a key driver of not just overall health, but in particular health equity, which will be a big frame and theme that crosses through our conversation today. And so one of those cardiovascular diseases of interest was atrial fibrillation. Atrial fibrillation impacts up to 60 million people worldwide, including about 6 million here in the United States. And it seems like almost every day there's a new research paper, a new lay press media post around atrial fibrillation. These are just a couple of the articles recently published over the last several weeks thinking about whether or not we should be screening patients for this diagnosis and what the cost effectiveness is around screening. So really hot topic areas in our cardiovascular field as a whole. Not only is atrial fibrillation in the scientific literature, as I mentioned, it's been in the lay press literature. And one of the reasons that it's really increasing the awareness is that the prevalence of AF is quite high. Again, 60 million in the world, 6 million here in the States. And as our population continues to age, we really see more and more increasing rates of this condition. There's a study several years ago, that citation there is incorrect, I should say 2001, excuse me, that said that 1 in 25 people by age 60 would have a diagnosis of atrial fibrillation, 1 in 10 by age 80. And meanwhile, there's a separate analysis in the Framingham study that put the risk as high as 1 in 4 individuals of those who are over age 40 having a diagnosis of atrial fibrillation. It's a really common, really prevalent condition that we see here, especially related to our aging population. Another reason we're seeing the high rates of AF in our country is that there's several risk factors, which are represented on this wheel on your screen here, that really are associated with higher rates of atrial fibrillation. And these are the risk factors we're taking care of every single day in clinic or in the hospitals, from smoking to alcohol dependence, hypertension, high cholesterol, obesity, chronic kidney disease, sleep apnea. As you move clockwise on this wheel, you see that these conditions are increasingly common in our society, and again, really raising the risk of atrial fibrillation across the country. And so why does this matter? Why is this so important? Well, it's not just a common condition. It's not just a condition that causes symptoms such as palpitations and discomfort, shortness of breath and stress and anxiety. It's a condition that leads to death. And you can see here across developed countries and developing countries, the high rates of mortality associated with a diagnosis of atrial fibrillation. And it's really increased over time and increased among men and women alike. One of the most debilitating complications of atrial fibrillation, as many of us on the call know, is stroke, the risk of which is as much as 5 times higher in patients with atrial fibrillation. And this is really the space that I work in around stroke prevention as a general internist. And it's a conversation that we'll be having today as we dive into really examining the social determinants of atrial fibrillation. And so that brings us to our second objective of the talk, really diving into these social determinants. So I showed that there was a slide of us thinking and studying these social determinants more broadly around cardiovascular disease. And over the last several years, it really put that focus into the social determinants of atrial fibrillation, examining how income influences AFib, how housing insecurity influences veterans with atrial fibrillation, how neighborhood disadvantage and health literacy impacts both incidence and management of atrial fibrillation. And these are some of the citations that we'll share with you all at the end of this webinar. But the focus of this talk is going to be on these 4 key social determinants. And I highlight these 4 during this talk, not to represent that these are the only important 4 the social determinants. There are several topics that we will not have the opportunity or time to discuss today, including rurality and its impact on patients with atrial fibrillation, LGBTQ+ communities, and how they differ in terms of their rates and management of atrial fibrillation. So again, I just want to make that emphasize that point here, that this by all means is not an inclusive list. And these are the 4 that we're going to reflect on today: race, socioeconomic status, health literacy, and environment. So let's dive into a conversation around race as a social determinant of health. And before we dive specifically into this social determinant, I think it's really important to have a couple of definitions to help orient our conversation. And so the first definition is that of race, and that race is a created social construct and not biological fact. And that really this definition has transitioned across centuries, where certain groups have certain racial or ethnic identities in one year, the next year they're different, the year after that they're different. And so really in our society, this is a construct that we have created over time, and I think it's important to emphasize that. Racism is the next definition that I want to emphasize here, which involves one group having the power to carry out discrimination through policies and practices and shaping the cultural beliefs that support them. And really the conversation today is around policy and practice and how those have been baked into the social fabric of our society, especially here in the United States. And so, as is the case with many chronic diseases and conditions that you all may study, and in particular with atrial fibrillation, there are significant racial and ethnic inequities that exist across the care continuum of the disease. From the risk factors associated with atrial fibrillation, detecting and screening atrial fibrillation, treatment of atrial fibrillation, which is where we'll spend the majority of this discussion, and lastly, rates of complications. And so whether that's stroke, myocardial infarction, heart failure, or mortality. And so again, you can see that there's varying rates of risk factors where racial and ethnic minorities, for example, have higher rates of risk compared to those who do not hold underrepresented backgrounds. There's differential rates of detection of atrial fibrillation, with several studies showing poorer incidence of this condition among underrepresented individuals compared to their white counterparts. And again, we'll dive into a full conversation on treatment, which is really where my research focuses and where the majority of research around racial disparities in atrial fibrillation has lived. And so as a generalist, I mentioned stroke prevention is really my focus. And it was really that, and the reason that I got into this space is that up until around when I started medical training back in 2009, there really was only one drug available to manage stroke prevention and atrial fibrillation. As our friend Farmer here is representing, warfarin or Coumadin was really the only game in town until 2009, when this newer class of medications called direct oral anticoagulants, or DOACs, as I'll refer to them throughout the talk, really have changed the game in atrial fibrillation. And so not only have these medications been shown to perform better in terms of stroke prevention and some other risk factors, as you can see from this study published in 2019, but these medications have been shown to be safer and more effective in many ways, easier to use. You don't have to titrate your warfarin or Coumadin dose, or DOAC dose rather, in the same way that you had to with warfarin and Coumadin. You don't have to bring a patient in to get their blood levels checked every 6 weeks to make sure that they're in the right range for their warfarin. And so these medications have really changed the game, as I mentioned, in managing atrial fibrillation. And it's what has inspired my work over the last several years to really try and understand how race and ethnicity might influence the rate of use of these medications. And so I don't expect you all to be able to tease out all the odds ratios on this slide here, but it's really been fascinating to see that across several years of study and across different registries, different health systems, as I'll reflect over the next several slides, that the matter of racial disparities in atrial fibrillation treatment has been clear. Across each of these studies, we've seen that Black patients in particular have poor outcomes compared to their treatment outcomes compared to their white counterparts. So we'll focus on the first 3 studies on the screen here as I share a little bit about what we found. So in our first study in 2018, the finding was that Black patients had about a 27% lower chance of getting prescribed with one of the newer direct oral anticoagulant medications compared to white patients. And that's somewhat reflected in this bar here, representing again who was more or less likely to get the newer DOAC medications compared to who is more likely to receive them. So 27%, that's the number that I want you all to pay attention to, is how likely Black patients were to get these newer, more effective, easier to use medications. And this is what we found in the one of the outcomes registries for better informed treatment trials, or Orbit AF2. We'll publish that study in 2018. 2 years later, we decided to look into a Medicare registry to see that if patients with the same insurance type also happened to have similar racial disparities in their treatment. Sure enough, not only did we see very similar numbers, so here we see a 25% lower chance of Black patients compared to white patients getting direct oral anticoagulants. But again, we found that finding amongst patients who have similar insurance through Medicare. And so again, we had a chance to publish these findings back in 2020. Along with my institution role in the University of Pittsburgh, I also have a role in the Veterans Health Administration here in Pittsburgh in our Center for Health Equity. And I decided that it would be really, really fascinating to try and examine whether similar disparities took place in the VA. The fascinating thing about the VA is that not only are medications far more affordable than outside the VA, so my patients pay anywhere from $5 to $11 for a prescription of any medication, whether it's the newest, fanciest cancer medications or the tried and true warfarin blood thinner medications. And so that really low copayment for medications, I had hoped would be able to help at least start to alleviate some of the racial disparities in treatment. Unfortunately, they did not completely eliminate those disparities. And so for orientation on this slide here, the racial and ethnic groups are represented in the left-hand column. And here we're looking at white, Black, Hispanic, Asian, and American Indian Alaskan Native patients. In the middle column, we're looking at whether patients received any blood thinners, so either warfarin or the newer DOAC medications. And in the right column, we're looking at whether they received DOAC treatment. And so if we just focus on the right column, we see again, this 25, 26, 27% number is really what we see across all three studies we're talking about today. In the VA, a 26% lower chance of getting these medications. Hispanic patients had about a 21% lower chance of receiving these therapies, and American Indian Alaskan Native patients a 25% lower chance. So all in all, the story is telling us that we have a lot of work to do in trying to understand and examine why racial disparities exist in treating patients with atrial fibrillation. And I think the story also told us that perhaps socioeconomic status or finances or income is not the full story, because those disparities existed even in a low copayment, all access health system like the VA. Well, what else have we seen when we talk about socioeconomic status and atrial fibrillation? That's what we'll dive into next here. And so atrial fibrillation is not just a really complex condition, as we've already talked about, one associated with high morbidity and mortality. It's a really expensive medication to treat and to manage in our health system. And this is a study published back in 2020 that showed just how costly it is to manage atrial fibrillation. And if we start at the top right bucket there, you see ambulatory care or outpatient care existing around 30% of the payment structure. Inpatient care, another 30%. Prescriptions, what we spent a lot of time talking about in the last several slides, about 11%. Nursing facilities, I mentioned that strokes are a really big complication of atrial fibrillation, and that's where a lot of patients end up receiving their long-term care. And again, that's a really costly type of care, including emergency department care, making up about $28.5 billion of treatment within our healthcare system. But the socioeconomic status conversation extends beyond just how much it costs the health system, but it really captures how our patients with high or low socioeconomic status have their care impacted. So those data are actually pretty limited, and really a lot of that data has come from across the pond in Europe. And so this is a study that took place in, there's studies that take place in Sweden, but there's also one study that took place here in the US that really showed that patients with low socioeconomic status, and that's represented by the less than $25,000 as their median household income, compared to those who are making $50,000, had unfortunately poor outcomes when it came to atrial fibrillation. So poor outcomes and also higher rates of AFib. And so here you see that when we controlled for various factors, including age, sex, and race, cardiometabolic factors, as well as other cardiac diagnoses, that patients with low incomes are actually more likely to have a diagnosis of atrial fibrillation. And so that's what the top bar represents here. And the bottom figure I added here to show, again, this conversation around race and socioeconomic status does extend beyond just income. And so we see that even among patients who have low incomes, that there's actually higher likelihoods of developing atrial fibrillation if you're white compared to if you're black. And we saw that as well in patients with median incomes. Again, a bit of a higher likelihood of developing this condition if you're white compared to if you're black. So the racial differences that we saw in treatment may not just focus again on socioeconomic status. And I really want to emphasize that point, because I do think it's time for us to dig beyond just thinking about how your class may influence racial differences in care. So what else around atrial fibrillation and socioeconomic status? So that association is not just related to developing or incidence of atrial fibrillation, but also overall survival. So this is the study that I wanted to refer to out of Sweden that shows that patients in the highest income group, which is represented by the green line on your screen here, had the highest survival rate at 1 year compared to those in the lowest income group, which is represented by the red line on this screen. And so again, it's suggesting that patients with more income have higher quality, have higher survival, have more life lived compared to those with low income. And we can imagine many different reasons why that would be the case, but this is a really striking difference, as you can see on your screen here, and one we have to pay really close attention to. And so what about thinking about those who have this diagnosis, who are staying alive, and how they are able to experience their quality of life? Well, there's a really interesting finding that one of my colleagues here at the University of Pittsburgh published a couple of years ago. And she examined affect scores, or the atrial fibrillation effect on quality of life score. And this is a score that has 4 different subscales of symptoms. So daily, are you able to what symptoms do you have related to your atrial fibrillation? What do your daily activities look like, and are you able to engage in your daily activities? Do you have concerns around your treatment for atrial fibrillation? And are you satisfied with your treatment? And this is a score that goes from 0 to 100, and it's really the most commonly used score to examine quality of life in patients with atrial fibrillation. And so in this study, Dr. Gould, adjusting for age, sex, race, and some clinical factors, was able to show that the higher your income is, the more likely you are to report a positive quality of life with atrial fibrillation. And again, I just want us to sit with that finding for a little bit, because I showed you that patients with low income are more likely to hold a diagnosis. They're more likely to die, less likely to survive if they have a diagnosis of AFib. And now we're showing that even in those years lived, that they're less likely to report high quality of life. And that's related not just to, I don't really love the life that I'm living in general, but specific to their diagnosis of atrial fibrillation. And so how often are we as clinicians, as researchers, thinking about patient-related outcomes, not just the big outcomes like stroke, bleeding, and mortality, but how our patients actually live with this condition? These are some of the factors that we really have to start to address. And I think the only way that we can fully address them is by once and for all understanding how our patients' social determinants, social lives impact the care, impact their day-to-day lives with this condition. And so that's the socioeconomic status bucket of our social determinants. let's dive into health literacy. And this is a really important one. And a lot of focus has been around education as a social determinant. So how much school have you gone to? What grade did you graduate? Did you have a college education? What professional degrees did you have? But with atrial fibrillation, as my mentor, Dr. Jared Mignani, often likes to reflect, this is really a complicated disease. It's the perfect storm, as he likes to put it. And so why is AFib the perfect storm? And sadly, Dorian was one of the hurricanes that came up the first time I gave this talk back in 2019. We know our community in Puerto Rico is experiencing continued challenges around weather, and really thinking about that community in this time. This perfect storm around atrial fibrillation, though, really reflects on the fact that this is a chronic condition. It's a condition that people have for a very long time. It's not just a one-off visit to the doctor, one-off visit to the emergency room or the inpatient ward, but it's something that they hold for decades, potentially, if they're able to live long enough. But it's also a condition that can come and go, right? It's symptoms, those symptoms related to palpitations or heart rhythm disorders, are not something that they may feel every single day. And so a patient might say, oh, I had atrial fibrillation yesterday, or I felt like my heart was fibrillating a couple of weeks ago. But maybe it's not something that they think about on a day-to-day basis when they are not having those symptoms. It's weird terminology. I think I've used the phrase AF, AFib, and atrial fibrillation dozens of different times already in the few minutes that we've been together. And you can imagine how our patients and communities may understand this condition. Some people call it an irregular heart rhythm disorder, a cardiac dysrhythmia, or an arrhythmia. And again, it's really complicated and it's hard terminology for patients to appreciate. Obviously, it's associated with bad outcomes, like I've talked about already today, including if you add on the treatment, such as blood thinners that complicate patients' lives, complicate other medications they may be on. The awful medications we already talked about, and really challenging adherence. Patients with warfarin are having to control and monitor their diet or other medications that they may be taking. But also patients who are just on a blood thinner in general may have to be thoughtful about that ski trip that they plan to be on, or family members may have to be careful around whether they are comfortable allowing a patient to live alone at home, because they worry about how they're going to get up and down the stairs because they just had a fall a couple of days ago. And now here's the doctor telling them they need to start taking a blood thinner medication, or a medication that's going to slow the heart rate and maybe even their blood pressure down. So this is really, again, a perfect storm, a really challenging, complex area of study. And it's not something as perhaps more clear or evident as a heart attack, for example, for some patients, or diabetes. I check my blood sugar, I start to take my insulin. We don't really quite have the same opportunities when we're dealing and managing atrial fibrillation. And so what do our patients think about this diagnosis? So one of our chief residents a couple of years ago asked several patients, about 250 patients in our clinic here at the University of Pittsburgh, what do you think about atrial fibrillation? And specifically, what is atrial fibrillation? And these are some of the comments that our patients made in this study. They described it as a weakening of the heart. Someone said, I just can't tell you. I don't know what this thing is. All I know is that it scares me. It's like, this is my favorite one, the little pitter pattering feet running up against a wall, super vivid. And I think you can almost picture that as you're talking to someone. Heart valves not working right, trying to catch up, and blood pooling that could burst a vessel, probably reflecting on the stroke risk that they may have heard about related to atrial fibrillation. So none of these patients are saying that this is a heart rhythm disorder that increases your rate of atrial fibrillation, or some of the classic conversations that we learned about in medical school, nursing school, or during our pharmacy training. But really, I think it's so important for us to capture this perspective, to be able to understand how much or how little our patients might appreciate about this condition, especially in the context of the myriad other conditions that we're managing that they are managing on a day-to-day basis. So that was one part of this interview, or of this study that we did. And the second part our resident led, she asked the patients about what they estimate their stroke risk of being. So I haven't spent much time on the CHADS-VASc score. Again, for those of us who are clinically practicing, it's one that we're familiar with. But this is the risk score that we calculate to determine how likely it is that a patient is going to develop a stroke in the next year. And this risk score captures a patient's clinical diagnoses such as heart failure, diabetes, a previous stroke, or any other peripheral or vascular diseases. And it also captures factors such as their age and their sex category. And so based on that score, we're able to estimate a patient's risk of stroke being anywhere from 1 to 10% over the next year. And it's really fascinating because we wonder how often are we having these specific conversations with our patients when we tell them and ask them, how comfortable do you feel starting a new medication to help decrease your risk of stroke? I already shared with you all that stroke risk is 5 times higher in patients with atrial fibrillation. And so we asked the patients, what do you think your stroke risk is in the next year? And you can see that a lot of patients really hovered around this 50% mark. And based on their stroke risk score, which was anywhere from 0 to 10%, we try to capture how likely they are to determine what their stroke risk is compared to what their actual risk is. And this has now been one of my favorite questions to ask my residents when I'm in the hospital, because as much as we have a trouble trying to capture that risk, our patients do as well. And again, I think that really matters when we're having these conversations with them about starting new medications, about not starting new medications, and really estimating their risk. And so understanding how our patients examine and understanding how our patients' health literacy estimates their risk of stroke, their understanding of this condition, these all are falling within this health literacy framework of social determinants of health. And so in another study published about 5 years ago now, there was a couple of colleagues who were trying to understand about patient-facing instruments related to atrial fibrillation symptoms, including the AFib score that we talked about earlier. And they tried to examine how readable these tools are, these materials are that we provide our patients with. And so they used various different reading level measures, such as the Flesch-Kincaid or the SMOG. These are some of the classic health literacy models. But really what's important is kind of understanding what these numbers are. So I mentioned that the effect score is one that we used in a previous study. And this has a 13th grade, so about a senior or a freshman rather in college, readability level. And the New York Times, in most articles are around the 10th grade level, but we aim for about a 5th grade reading level in a lot of our materials for our patients. So again, it makes you wonder, as we provide patients with discharge summaries, with the handout after they see us in our clinics, how readable are those materials? And this is something that I know the AHA has been really strongly working on. There's materials available at stopafib.org to hopefully be able to simplify our patients' treatment plan, to help us as clinicians who are having conversations with our patients to be able to make them the best possible, and also to be able to help caregivers, so family members, spouses, children, whoever is coming in to help our patients and community members have these conversations around their stroke risk. And my hope is that factors such as the CHADS-VASc score, it's a mouthful, it's really difficult to say, but as folks become more and more familiar with these scores, they can also be able to better titrate what it means to be able to start or not start a medication to help prevent strokes. And that's really what we're all about, helping prevent symptoms, helping prevent strokes, and hopefully in the long term, keeping our patients to be able to live the healthiest lives possible. And so our last social determinant of health, the environment. I think this is really, really critical, and one that sometimes on a day-to-day basis may feel impossible for us to manage on a clinical day. How much can I really impact the environment that my patients are coming to me from, or the world that my patients are living in? But it's one that we have to address, and we have to not just address in our day-to-day clinics, but also start as a society, I believe, to advocate for the better health of our communities and environments. And so I've been here based in Pittsburgh. I've been here for about 4 years now. I've heard concerning things about pollution here. Our colleague Gino is also from the area, but I'll have to admit that where our air quality is still is on the up and up, certainly not where it used to be back in the bad old days, quote unquote, where the steel mills really kind of thrived in this community. But this is not just to talk about Pittsburgh, right? This is a conversation I imagine many of you are having depending on the city that you're living in, whether it's the smog-filled Southern California cities, or even here in the closer to the Midwest areas where experiences of flooding and other environmental challenges we're seeing every single day. Talk about Jackson, Mississippi and its experiences around its water. Of course, we just referred to Puerto Rico. And so environment is critical to the health of our patients. And I'm here to share that it's also critical to our cardiovascular health. There have been several studies published over the last decade or so have really made that connection to in the environment that we live in and cardiovascular health. And some of the work that our colleagues, myself and our colleagues have done over the last few years have really brought that specifically to atrial fibrillation, really providing a framework for how to understand how air pollution, for example, is influenced by the social factors. So where in your city your patients or community members are living in, and how that might differ from where you live on a day-to-day basis, and how that may differ from the exposure to pollution that they have. And so air pollution influences our patients' risk factors for cardiovascular disease, such as hypertension, diabetes, and chronic kidney disease. If you might remember, about 20 slides ago, I told you all that those are some of the factors that increase a patient's risk of atrial fibrillation. And so again, we're seeing direct correlation between pollution and AFib outcomes there. We also have this kind of bottom framework where air pollution influences inflammation and thrombosis. And those two factors can influence one's risk of atrial fibrillation specifically, and also influence one's risk of ischemic stroke directly. So again, really understanding how the world that our community members are living in ultimately can influence this specific condition, I think is really critical. And there's data to support that. So a couple figures from a study back in 2019 that shows that not only do higher rates of air pollution as captured by particulate matter 2.5 or PM 2.5 increase one's risk of atrial fibrillation. So you can see the rising line with the higher rates of pollution exposure. It also has a direct linkage to higher rates of stroke. And again, that's represented on this figure here. In patients with atrial fibrillation, they have upwards to a 15 to 20% higher rate of stroke with higher exposure to pollution. And really, that was a similar study that we saw in a publication that we published back in 2020. And using data from Pittsburgh, we found that patients who were more likely to live without developing a stroke if they had lower rates of pollution exposure. So the highest pollution exposed population had higher rates of stroke over time. The lower rates of pollution exposure had lower rates of stroke over time at 10 months here, and it goes out to 1 year in our study. So again, wanting to emphasize that we have to think about the environment when we're thinking about our patients with atrial fibrillation. And so we did it. We touched on examining the social determinants from race to socioeconomic status, health literacy, and environment. And again, as I mentioned, this is not an end all and be all of the conversation. Perhaps there's some social factors that you all are studying in your day-to-day basis. You can put in the chat for us to talk about when we get into the question and answer period, or perhaps there's some literature that have come out in those spaces, and we'd love to hear about those as well. And so our last objective of the talk today is describing opportunities for future research in the social determinants. And the title of my talk today was Learning from the Past to Transform the Future, and was really inspired by this symbol here. This is a symbol of a Sankofa. Sankofa is a Ghanaian term which means to retrieve or to bring back. And it's really represented by a picture of this bird on your screen here who has its feet looking forward, facing forward with its head facing backwards. And it's holding on to this precious egg in its mouth. And this Sankofa, this bird, has been most reflected in one of the really common Ghanaian proverbs that says it's not wrong to go back for that which you may have forgotten. And it's really been adopted by folks in the African diaspora, myself included, to represent the need to reflect on the past to help build a more successful future. And that's what I think we're doing today. So we've highlighted the challenges around this really complicated, really increasingly common condition. We've talked about how the social factors are big drivers of health with this condition. But for years, we haven't paid as close attention, even since that AHA statement about really emphasizing the social determinants as the most significant way to manage cardiovascular disease. And my hope is that as we've reflected on these past literature and data, that it'll help us to be able to build a more successful future that really incorporates these social determinants of health. So how can we do that? Back in 2021, we provided a little bit of a framework, the kind of a stepwise approach for starting to address future research in this area. And the emphasis on this slide is on research, but I really want to say that the emphasis also needs to extend towards policy and advocacy to really make sure that our patients are living in environments, having access to the right education, the right amount of support for their regardless of their social class or racial and ethnic backgrounds. And so starting from the top, really having patient level research, really understanding how our patients are living through lives that are complicated by different social determinants, right? No one is just their racial identity, no one is just their social class, no one is just their health literacy level. So all of these factors really get interplayed. And really going out and talking to our patients, asking like our colleague Anna La Rosa did about what it means for a patient to have AFib and what it means for them to handle these various social factors as they're managing these diseases. So really get back to understanding this topic at a patient level. I think there's important to understand research on clinical interactions. Well, how do we as clinicians engage with our patients' social determinants? One of the papers that I shared on the screen earlier is around veterans who are homeless and their management of atrial fibrillation. And what we saw in a paper published earlier this year in JAMA Network Open is that veterans who were homeless were far less likely to be initiated on direct oral anticoagulant or the newer blood thinner medications. Why would that be the case? How are we as clinicians perhaps engaging in implicit bias around, well, is this patient going to be able to continue to come back to keep going on this medication? If they don't have a stable home, are they going to be living in environments where they're at a higher risk of falls, of bleeding? And so what do those conversations look like in our heads, perhaps, and not actually with our patients? That may end up having patients have lower exposure to important medications that they need. So we need a lot of work in that clinical interaction space as well. Community-based research, again, understanding more and more how the direct environment influences atrial fibrillation. And it goes back to that continuum that I showed earlier. So how does residential segregation, for example, influence rates of stroke or rates of death in patients with atrial fibrillation? How might rural environments really drive atrial fibrillation risk? Those are some of the factors that we need to start to learn a little bit more about. We need to build up our research infrastructure to be able to do this work and really start to think beyond and including precision medicine topics and genetic topics around atrial fibrillation to really build up our population health and health services research around these topics. These are some of the data that I think will really help us drive care at a bigger, broader, and population-based level. And lastly, we need policy implementation research. So bringing some of the data that I just shared with us today towards our policymakers who are actually going to be able to change where those factories are within the neighborhoods, who are able to change why and where we place new highways within our communities. And we know that those conversations have always greater influence the underrepresented and the most vulnerable populations. And that's how we really can use our research to change the policies and the environment that our patients are living in. So I hope in our talk I was able to address following the objectives on the screen: identifying atrial fibrillation as a model disease to study social determinants, understanding and examining some specific social determinants, including race, socioeconomic status, health literacy, and environment, and really providing a framework for opportunities for future research, the patient level, the provider and clinician interaction level, what's going on in our communities, within our research infrastructure, and lastly, thinking about how we can use our work to inform policy. So again, really grateful for the opportunity from the AHA and Get With The Guidelines to be able to share with you all today, and looking forward to any questions that you all may have. Thanks so much for your time.
Wow, thank you so much, Dr. Estienne. That was an amazing presentation on such a complex issue. We're going to begin answering some questions or presenting some questions submitted during today's presentation. So there's two questions here that sort of build on one another. One says, what are some of the strategies you've implemented in your own practice to address some of the issues you've discussed today? But there's also another question that says, we all ask the social determinants of health questions, but don't have strategies in place to address the findings. This is very frustrating. Does your team have an algorithm, a social worker, a nurse navigator, or all of the above?
Yeah, really important questions. And again, they do kind of play off of each other. So I mentioned that I'm based in the VA for a lot of my clinical practice, and we're really fortunate in the VA to really have wraparound services baked in to our patient care. And so a lot of what that last question asker referred to, we have social workers who are engaged in primary care clinics. We have some navigation services, and I think that there's really an opportunity for us to start developing specific AFib. And if we don't want to get that specific, cardiovascular, but I think there's a huge opportunity for us to leverage the expertise of our pharmacy colleagues, for example, who, with the really significant uptick in transition from warfarin to DOAC prescribing, are not spending as much time in the lab following up on warfarin levels or INR tests, and perhaps have a little bit more of an opportunity to help with navigating the care around atrial fibrillation, whether that's ensuring patients are on the right medication or ensuring access to the right clinical provider, including general cardiologists and electrophysiologists. So I think there's a real opportunity to continue to broaden those wraparound care services. If there is not those extra additional resources within the clinical space, there are several algorithms online to be able to ask these questions around social factors, around food insecurity, housing insecurity, income and employment, et cetera. And more, as I mentioned, the research has been available and the resources have been available to be able to address those, to be able to link patients who have housing insecurity with local resources here in Pittsburgh, for example, or in Western Pennsylvania, or in whatever states that you all might be living in. Those resources are really more than only just a click away. And so back in 2016, when I was in 2015, when I was in my residency, that was always the comment that was made. You know, we don't know what to do. We're collecting all these data. What are we going to do about it? But more and more of those resources are becoming available, and are even becoming available within our clinical settings as health systems are making themselves available to help support housing, help support food insecurity, even education for our patients. So I think the time is now for us to not just ask the questions, but to be able to direct our patients to the right resources they need.
Great, thank you. There's a question here of, do you see a challenge in research of the often presumed heterogeneity of the Black population and other minority populations where they're addressing race without considering ethnic background?
Really important question. And I think that extends beyond the Black population to thinking about how homogenous Asian populations, for example, have been for decades, where regardless of their ethnic backgrounds or their immigration backgrounds, how long they lived in the US, they're all placed within one small group. And so I think we have to really get creative with our research. Again, research infrastructure was one of the steps in that framework for future research. And it starts with the collection of data on race and ethnicity. And so how we collect those data, really encouraging its collection, ensuring that it's safe and patients feel comfortable and they trust us to know what to do with that information is going to be critical. So we must collect it first. And we must start to really disaggregate it so that not every group is placed within the same subtext. Because as I mentioned, my background is as a child of immigrants from West Africa. My parents had very different life experiences and very different clinical experiences when they engage in their healthcare compared to someone who has lived in the US for centuries and maybe descendants of enslaved individuals here in the United States. Very different experiences from an individual whose ethnicity is African American and Hispanic. And so I agree that really we need to think more broadly around the topic of race and ethnicity, and it really starts with accurate collection of data on the front end.
Fantastic. We're getting a lot of questions now, everything from about paying for DOACs to pharmaceutical companies, but we have time for one more question. I think this is a great one to end with. So the question says, thank you for your fantastic talk. What is your vision on how we as researchers and clinicians can partner with communities to address these disparities?
Absolutely, great question. And community is key. You know, the social determinants in my mind are not just going to be managed by health systems decided that we'll use a little bit of our extra funds to help link up with a food pantry in our neighborhoods. This really has to start with strengthening our relationship with the community. I think we've seen that in the pandemic where we leveraged the expertise, the brilliance of the community to be able to engage with folks who may not have been too excited about getting a COVID vaccine at the beginning of the pandemic, but lo and behold, as time went on, we were able to work with those communities to be able to get folks the vaccines that they needed. Those are the same ways that I think we can really start to address these social determinants. We're not going to be able to walk in with our white coats and stethoscopes into neighborhoods, into some rural neighborhoods and say, hey folks, you all need to get screened for atrial fibrillation with that Apple Watch that you might have on your wrist. That's just not going to be available to a lot of communities. But that person who's been living in that environment, who's been living in that community, will be able to help us realize, actually, this is where you need to go. Actually, these are the tools that you can use. Actually, this is the one individual, the one store owner that is connected to everyone in this neighborhood that we have to tap into to be able to start talking to patients about getting a Holter monitor or about starting a blood thinner to help prevent stroke with AFib. And I think the way that we're do that is by really prioritizing community within our research enterprises, within our clinical care. And I'm hopeful that in another 7-8 years removed from that first AHA statement around social determinants, we'll be able to develop those relationships even stronger.
I think we could talk to you all day about this. I wish I had a music clip from Earth, Wind, and Fire September to sign you out, but instead I'm going to hand you back to my colleague Gino for some exit information.
Thank you, Jeannie. Thank you, Dr. Essien, for such a remarkable presentation and your continued dedication to your community and to the American Heart Association. Thanks everyone for attending. Once you leave today's webinar, you'll receive a short survey, and we'd appreciate if you would complete that feedback. We also will be sending out the video of today's presentation within 24 to 48 hours with the link to view today's webinar. On behalf of the American Heart Association and Dr. Essien, thank you for joining us today, and have a great rest of your day, everyone. Thank you, Dr. Essien.
Thanks so much. It was a pleasure.
Thank you. I've heard a lot of talks, Dr. Essien, and that was probably one of the best I've ever heard. So kudos to you.
Thank you so much, and you really appreciate it.
Stay well.
Stay well, everyone.